Welcome! In this module, we will review the etiology, epidemiology, and transmission of dracunculiasis. We will then discuss the clinical manifestations of this disease and the tests available for its diagnosis. Finally, we will present treatment options and preventative strategies. Let's start with a few questions to get you to start thinking about dracunculiasis. We will review these questions at the end of the module to give you a chance to apply the knowledge you have gained. Question number 1. What causes dracunculiasis? Question number 2. Where are the endemic areas of dracunculiasis? Question number 3. What is dracunculiasis' main mode of transmission? Question number 4. What are the most important risk factors for dracunculiasis infection? Question number 5. What are the most common clinical symptoms of dracunculiasis? Question number 6. What is or are the intermediate host or hosts for the parasite larvae? Question number 7. What is or are the main diagnostic modality or modalities for dracunculiasis? Question 8 is a true or false question. Laboratory test or tests is or are commonly used for the diagnosis of dracunculiasis. Question number 9. What are the WHO eradicative measures against dracunculiasis? And finally, question number 10. What are the recommended treatment and prevention methods for dracunculiasis? Let's start with a bit of history. Dracunculiasis is one of the most well-known human parasitic infections. In ancient Egyptian texts, the quote, fiery serpent that followed the Israelites during their wanderings across the Red Sea is a reference to Dracunculiasis medinensis. This scientific name is derived from the worm's once prevalent occurrence in the city of Medina in Saudi Arabia. In the 9th century AD, Arab Persian physicians Rhazes and Avicenna described the disease in detail and called it, quote, Medina vein, or the, quote, little dragon of Medina. By this time, Persian and Greek doctors had been winding the worms on sticks to facilitate removal for over 2,000 years. This could very well be the inspiration for the symbol of medicine, the caduceus. In the 18th century, the clinical symptoms associated with dracunculiasis are named, quote, guinea worm disease, due to their high prevalence in the Guinea Gulf coast of West Africa. At the same time, Carolus Linnaeus hypothesized that, quote, guinea worm is a possible cause for dracunculiasis. In 1870, Alexei Pavlovich Fedchenko clarified the role of the intermediate host cyclops, a crustacean, in the life cycle of D. medinensis. In 1905 and 1913, Thomas Leper and Daneshvar et Maran described the guinea worm life cycle. Dracunculus medinensis is the largest tissue parasite known to humans. It belongs to the nematode genus. The adult female can reach 60 to 100 centimeters in length and carry up to 3 million stage 1 embryos. The adult male barely exceeds 4 centimeters. Humans become infected after drinking water contaminated with cyclops, more commonly known as the water flea. In the human GI tract, cyclops die and release the guinea worm larvae, which penetrate the intestinal wall and enter the abdominal cavity. Within the abdominal and retroperitoneal spaces, the worms mature and mate. The males eventually die. The females migrate from the subcutaneous tissue towards the skin surface. Approximately 1 year after infection, the female emerges from the skin and forms blisters, mostly on the surface of the lower extremities. Within days, the enlarged blister causes an excruciating burning pain that can only be relieved by water. When the female senses that it is surrounded by a water source, it contracts, causing its uterus to explode, releasing a characteristic, quote, white cloud that indicates the expulsion of hundreds to thousands stage 1 larvae. Although the larvae can swim and survive for a few days in water, Cyclops crustaceans must ultimately consume the larvae and serve as intermediate hosts in order for the maturation from L1 to L3 to occur. Cyclops transmit the infection to humans through contaminated drinking water. When the Carter Center first initiated the guinea worm eradication program in 1986, the incidence of Dracunculiasis in parts of Africa, Asia, and the Middle East was approximately 3.5 million cases per year. Since then, the number of new cases of guinea worm disease, or GWD, declined significantly. In 1989, the WHO reported approximately 900,000 new cases in 15 to 20 endemic countries. In 2008, the Gates Foundation reported that only 6 countries are endemic areas for GWD. In 2012, the CDC reported approximately 550 new cases, which was a 50% reduction compared to 2011, and more than a 99% reduction compared to 1986. Approximately 96% of the cases in 2012 originated in southern Sudan. The remainder of cases were from Chad and Ethiopia. GWD places a significant socioeconomic burden on affected communities. A prospective study from Benin shows that an average of 19% of working days are lost due to dracunculiasis. The same study shows that in poor endemic areas, affected adults withdraw from the workforce and are replaced by children who are forced to leave school. GWD is both a disease of poverty and a cause of poverty. It is endemic in the poorest 10% of the world's population in those communities that have no access to safe drinking water and health care. The annual cost of the disease on community economy has been estimated at $60 per person, corresponding to 15% of a worker's income. In dracunculiasis-infected areas, the dropout rate from school among children is approximately 60%. The risk of acquiring guinea worm disease varies by sex, age, ethnicity, and profession, and is a reflection of how local people access drinking water in different areas. Guinea worm disease is equally distributed among men and women. Although all age groups are affected, the disease is seen most frequently among teenagers and adults between 15 and 45 years old. Farmers and other professionals who are in close contact with shallow water are also at increased risk. The single most important risk factor for guinea worm disease is previous personal history of the disease. Unfortunately, in most instances, the initial risk factors such as contaminated water resources and human living conditions supporting guinea worm spread are still unchanged. Studies have shown that some people are more likely to suffer from recurrent episodes of guinea worm disease compared to others in spite of drinking from the same water supply. These findings can shed light on the variability of individuals' susceptibility to disease. Reports have shown that increased incidence of dracunculiasis is closely related to increased community mobility. In some cases, scientists have been able to trace a direct link between an individual's movement and a following outbreak in a community that was previously free of guinea worm disease. After human ingestion, it takes roughly 1 year for a larva to emerge into an adult worm. This delay makes the worm fit for seasonal transmission. In northern Africa, incidences of dracunculiasis peak during the rainy season. In the savanna and forest zones, dracunculiasis peaks during the dry season. Patients with guinea worm disease remain asymptomatic for 10 to 14 months after the primary exposure. Eventually, they experience low-grade fever, nausea, vomiting, itchy rash, diarrhea, and dizziness. In 80 to 90% of cases, an extremely itchy, enlarging blister develops on the lower extremities from which the worm finally emerges. Guinea worms are diagnosed clinically as they approach the dermal tissue and form painful nodules. The nodules subsequently enlarge and rupture to release the stage 1 larvae. Because of its typical presentation in endemic areas, guinea worm disease does not require laboratory confirmation. At present, no medications are available to prevent or treat dracunculiasis. Avoiding exposure to the worm is the only way to prevent the disease. Pain is managed symptomatically with analgesics. Antibiotics have an important role in management of superimposed bacterial infections. Management includes removing the worm and caring for the wound. The CDC's recommended strategy for guinea worm disease treatment are as follows. Number 1. Daily immersion of the affected limb in a contained source of water and prohibiting the patient from contact with drinking water sources. Number 2. Cleaning the wound. Number 3, slow, gentle, daily traction of the worm. Number 4, topical antibiotics to prevent superimposed bacterial infections. And 5, proper wound care and analgesics. The worm is removed through the use of a stick at a rate of approximately 1 to 2 centimeters per day. The entire process can take weeks. If at any time during removal the worm breaks, the remaining part inside the human body degrades and causes intense inflammation, swelling, and cellulitis. The calcified remnants of the dead worm have been associated with a variety of rheumatic manifestations, including localized myalgia, chronic monoarthralgia, and chronic synovitis of the knee. Guinea worm disease chronic ulcers are rarely reported to have precancerous potential. In case of inappropriate care, there can be superimposed bacterial infections of the wound. These superimposed infections can further increase the severity of the clinical scenario and result in any of the following complications: cellulitis or local infection of the skin, abscesses, sepsis or septic shock, tetanus, the most common cause of mortality among guinea worm disease patients, and septic arthritis, which results in contracture deformity and permanent disability. The following principles make up the backbone of the guinea worm disease global eradicative program: early detection and isolation of new cases, which involves prompt patient care in terms of wound dressing and to limit sick persons' contact to water sources. Promotion of clean drinking water access, which includes providing water filtering supplies and larvicide for vector control. And education, to teach communities about the transmission route of guinea worm disease, to teach communities to fight against guinea worm disease, and to help communities realize the importance of clean water and filtering. Fortunately, the global eradicative efforts to lower the incidence of guinea worm disease have been successful. Due to these efforts, the number of new cases in 2012 based on CDC reports does not exceed a few hundred. Let us return to the questions that we began with at the start of the module. Question number 1. What causes dracunculiasis? The answer, Dracunculiasis medinensis, or guinea worm. Question number 2. Where are the endemic areas of dracunculiasis? The answer, Africa, Asia, and the Middle East. Question number 3. What is dracunculiasis' main mode of transmission? The answer, drinking water contaminated with cyclops containing the guinea worm larvae. Question number 4. What are the most important risk factors for dracunculiasis infection? The answer, the single most important risk factor is previous infection with dracunculiasis. Other risk factors include residents in endemic areas, teenagers or young adults, and prolonged exposure to shallow water sources, for example, farmers. Question number 5. What are the most important clinical symptoms of dracunculiasis? Nonspecific findings: slight fever, itchy rash, nausea, vomiting, diarrhea, dizziness, followed by development of a growing blister, localized sore, and burning. Question number 6. What is or are the intermediate host or hosts for the parasite larvae? The answer is Cyclops crustacean. Question number 7. What is or are the main diagnostic modality or modalities for dracunculiasis? The answer is that this is a clinical diagnosis. Question number 8 is a true and false question. Laboratory test or tests is or are commonly used for the diagnosis of dracunculiasis. As we noted in the previous question, this is a clinical diagnosis, and this statement is false. Question number 9. What are the WHO eradicative measures against dracunculiasis? The answer is early detection and isolation of new cases, promotion of clean drinking water access, and education. And question number 10. What are the recommended treatment and prevention options for dracunculiasis? As mentioned earlier, there are no medications available to prevent or treat this disease. Pain can be managed with analgesics, and antibiotics can be used in the management of superimposed bacterial infections. In terms of prevention, the most comprehensive guidelines are those that are provided by the WHO as part of their eradicative program. This concludes our module on dracunculiasis. Thank you for your time.